Okay. Almost. Oh, it's recording in. Ooh, okay. Tape number 3. Hi, this is Sandra. I'm going to be talking about the two theories that has that I've been interested the most in this class, and that is Dorothea Orme and Ms. Kalapa, that does conflict theory. Miss Dorothea Orme did self-care deficit theory based on the individual's quality of life. She developed this theory in hopes of improving quality care to sick individuals. This theory is used a lot in my practice due to the fact that I work in long-term care and that a lot of patients that I receive actually need to go through rehab for either strokes or heart attacks. A lot of them still come to the rehab department for due to the fact they had surgery, but they need help as well because they can't walk to the bathroom. They have to be assisted on the bedpans or assisted to the bedside commode until therapy is able to get them to walk to the bathroom once again. Depending on whether it's their hip or knee that has they have had surgery on. She also talked about her theory being from simple, which is generalized, to specific, depending on the sickness of the individual. The self-care deficit can be used by nurses to guide and improve in their practice, but it must be consistent. Consistent means to us is that we try to put the same CNA with the same set of residents. We have the nurses have that same set of patients every day when they come in, unless they come in on an off day. And sometimes when they come in on an off day, the nurses may be good enough to switch around with them since they know that it's our regular scheduled assignment and they're coming in to help one another. So they're willing to switch assignments. Nursing assistants does the same, depending on whether we got 3, 4, 5, how the assignments is divided up. But each CNA knows what to do with different particular residents based on their level of need. According to Dr. Orme, individuals as persons, a person struggling to have self-care needs met in order to live and mature. Basically, that is saying that if they cannot get back to their prior level of functioning, then their self-care needs may not be met. Therefore, they are dependent upon the nursing staff to provide those self-care needs. And some of the self-care needs is bathing, feeding, keeping them clean and dry, keeping them turned if necessary, if they're not able to get up out of the bed. Her theory truly relies on the individual. You cannot really group them and state that this is what we're going to do for this group of patients. No, we must individualize the self-care need, because just because patient A had a stroke and this is what we do for patient A, it's not necessarily true that those same interventions will work for patient B. We have persons that provide care plans, and we use care cards for the CNAs to go by when a resident first admitted to the facility. We basically go in and assess them and see exactly what their needs are, just to the point that we can determine exactly how much help they may need in the beginning to the end. Some may not need any help based on why they're there. Some would need extensive assist, and that's how the facility get paid based on the actuality of the type of assistance that they may need. We use, what is it we call this? The function of care based on whether it's minimal assist, limited assist, extensive assist, total dependence, and also whether it takes one or two people to take care of that resident doing whatever care they're doing. Such as if I'm able to get up and go to the bathroom on my own with somebody just standing there, that is supervision. But if I have to have someone to hold on to me while I'm walking to the bathroom, that's a limited assist. Having to have the person to really hold on to me, help me undress to go to the bathroom, that's extensive assist. Total dependence is that they can't do anything for themselves. So therefore, that makes our job that much more difficult to return them back to the fact of being able to do some things for themselves. The self-care deficit theory was great. I'm glad she developed it to give people guidance as to how to take care of the residents as they come about. Miss Orm was actually born in Maryland, which is a good 4 or 5 hours from where I live. I also have visited Providence Hospital where she got her nursing started, and they are still using her theory in that particular hospital. My other theory of choice is the comfort theory. I chose that because in dealing with people that come in that have had strokes and heart attacks, and their lifespan has been told by the doctor that it's limited, we work very carefully to make sure that they're kept comfortable during this time. We also try to provide some independence. Some may not be able to do that independence as easily as others, but we try to offer that as much independence as we can. The comfort theory, major concepts, focuses on healthcare needs, the comfort, enhanced comfort, and institutional integrity, best protocol, best practice. Now, with each one of those, it is very definite and individualized. We use that Orm self-care deficit as well as the comfort theory to make sure that the people that we taking care of are being taken care of based on their needs and what kind of quality of life they have. The comfort care theory comes mostly in place in long-term care when you have residents that is deemed to be hospice, or they just rather pass with dignity at the end of life. We have a form that we go by that we show to the family and offer it to them to make transitioning for them easier. It gives them an idea exactly what we will be able to do when that person's time comes at the end of their life, as far as keeping them comfortable and making sure they're very well taken care of. Some families still can't adjust to the fact that their loved one is passing. So it's up to us nursing staff to make sure that the family is comfortable as well, not just the patient. I think when I first started out in nursing, we made sure we took care of the resident, and the resident came first. Well, this day and time, the resident still comes first, but you still have to take care of the family, because if you take care of the family, then the family is more at ease if you're taking care of that loved one. And this theory also helps you provide safe, effective, quality care practices. If the nurse follows the comfort theory, it can enhance comfort care and greater satisfaction. This comfort theory has concepts and proportions and propositions rather specific to nursing. It can be applied to any institution, any setting, and any client. The concept of this theory is to address needs, reassessments of patients, families, and the community comfort. Healthcare needs, comfort interventions are variables that is the main concept of this theory. Therefore, it just tells us that you have to involve the resident, the family, the doctor, the nurses. Everybody needs to be involved in the care of the individual residents. whether we need to discuss the self-care deficits of that person or comfort measures of that person. And thank you for listening to this video, talking about Dorothea Orme and Dr. Kalaba. Thank you. Answers? It went off. I ain't do nothing. I ain't touch a thing. I rang because I said, thank you, stop.